Morning, everyone. I hope you can hear me fine. Welcome to our webinar. My name is Simona, and I will be your host today, together with my colleague Raquel. We will moderate this meeting. As some of you might know, this webinar is the last one from our webinar series this autumn dedicated to the topic of health inequalities among people experiencing homelessness. And so I will start with a few brief technicalities. We are in meeting mode on Zoom. And as you may have noticed, we are recording. So in case you do not want to appear in the recording, which will be later available for those who couldn't join today, you can still stay with us, but keep your camera off. We are very much encouraging you to send us your questions or share your experiences in the chat, and let us know where you're joining from and what is your experience with the topic that we are discussing today. And also, please remember to remain muted because we can hear everyone since we are in a meeting mode. So the last webinar today is dedicated to the issue of mental health issues among people experiencing homelessness. It is a topic that has been of interest in the past years at European level, and for us at FEANTSA as well under our work on health. And I will not take a lot of time. I will not give a presentation. I will pass it on to Raquel to introduce our experts, because we have with us four experts who will carry us through data, policies, and practices that lay at the intersection of mental health and homelessness. But I would like to set the scene briefly, and just to do that, I will say that, well, in 2023, data have shown that 62% of European citizens have been to some degree affected by mental health issues in the context of all the crises and the conflicts that were happening in the world. And it's very likely that this percentage doesn't include people experiencing homelessness, because it's Eurobarometer data, and that often doesn't take into consideration experiences of homelessness. But even so, we are very much aware that mental health can be both a cause of homelessness and also a consequence of people not having safe shelter. So this is why it has been of interest for us at FEANTSA and our members. The homelessness sector in general has developed support practices and has looked into this topic quite extensively. So finally, I would also like to mention that in 2023, probably because of all the data that showed a lot of increase in mental health problems among European citizens, the European Commission has set up a communication at European level called the Comprehensive Approach on Mental Health. And in that context, we have intensified our work and our efforts on this area. And so today we are here to learn about updates from European level, but also to understand how should we go on with our advocacy efforts, and to make sure that we ground our work in the future on mental health and homelessness into experiences from the ground and updated information and data. So with that, I will thank you very much for joining, for your interest, and I will pass it on to Raquel to introduce our great speakers and kick off the presentations. Thank you.
Simona. Hello, everyone. I'm Raquel. I'm the Health Policy Assistant here at FEANTSA. We are excited to be here with you today. I hope this webinar will provide us an interesting and meaningful conversation about the specific needs and challenges faced by people experiencing homelessness regarding mental health, as well as explore good support practices. To ensure a truly comprehensive and effective approach to mental health at the European level, the needs and access of people experiencing homelessness must be considered. Today, we will have 4 speakers from different countries and organizations. After the presentations, we will have a moment for discussion in our Q&A session. But first, we will hear from Fatima Awil. She's the Policy and Knowledge Officer from Mental Health Europe. Following her presentation, we will hear from
I
Istvan
think I might have taken mine.
from University of Hungary. Istvan will have to leave us a bit earlier today, so we will spare some minutes in case someone wants to have a specific question regarding his presentation. But for now, I will give the floor to Fatima. Thank you so much, and Fatima, you can start whenever you want.
Thank you so much, Raquel, for the lovely introduction. And hello, everyone. It's a pleasure to be part of this webinar. I will just briefly introduce myself, but Raquel already did it. But indeed, my name is Fatima, and I work at Mental Health Europe. I've been there for nearly 4 years, and I focus my work really around children and young people, education, migration, and vulnerable situations. So intersectionality is really encompassed in the work that I do. So I will be presenting for around 15 minutes, and I will start off by giving a brief introduction at the work that we do at Mental Health Europe and the focus we have around mental health. And then I will dive into the psychosocial approach to mental health and why this is essential to ensure a comprehensive approach to mental health. And if I have some time at the end, I'll just include a few recommendations as to what we would really like to see when it comes to mental health and addressing homelessness. During my intervention, if you have any questions or would like me to, dive into anything more, I'm really happy to expand during the Q&A. So for those that aren't aware of who we are, Mental Health Europe is the largest independent network organization representing professionals, service providers, service users, and persons with lived experience across Europe. We are a membership-based organization based in Brussels, Belgium, and we have over 90 members in over 30 European countries. And we focus really on promoting mental health, the prevention of mental health distress, but also the improvement of care, advocacy for social inclusion, and the protection of the rights of users and ex-users of mental health services. So here, it's really important to also work with persons with psychosocial disabilities, their families, carers, and also wider communities as well. And I'm basing my presentation on an article that I wrote with a colleague of mine on mental health and homelessness last year. And it really highlighted that the intersection of homelessness and mental health creates intricate challenges, resulting in difficult situations for individuals that are in this complex web of circumstances. And the intertwining of these problems really can exacerbate the difficulties faced by individuals lacking a stable place to call home. And we've highlighted that, when it comes to mental health, there has been more visibility over the last couple of years at European level, which is fantastic to see because it has created a dialogue around what mental health is for us and what is needed in terms of support, but also prevention and promotion. And despite the strides made in acknowledging the importance of mental health, we recognize that the persistent plight of homelessness continues to pose a challenge. And mental health and homelessness is interconnected, and we need to ensure that we address both together through intersectionality, which I will dive into a bit later on. And since mental health and homelessness is interconnected, without recognizing the complex barriers that are at play, it's not really possible to build a more equal society through equity. So Simone at the start mentioned indeed that there has been some progress at European level. In June 2023, the European Commission released a communication on a comprehensive approach to mental health, which was quite exciting because it really it was an initiative focused on mental health that we don't see every day. And as an organization, we mainly push for two things within our advocacy, which is all-encompassing. One is ensuring the mainstreaming of mental health, so mental health in all policies, and we value this because mental health is an area that touches so many different sectors, environments, and mental health is as a human experience. So it needs to be integrated into all different areas, at least considered to see how it could be better intertwined into policies and legislations, initiatives, funding, etc. But also, we've been calling for many years for a European strategy on mental health. And this is a really comprehensive strategy that includes, clear indicators and benchmarks backed by funding, because this will allow us to really be able to monitor progress on mental health across the European level for years to come. And I want to clarify that we haven't yet achieved that. The communication is a great step in the right direction, but we continue to advocate for a European strategy on mental health, which we're really happy to work with FEANTSA on. So just to briefly highlight the challenge across EU member states, it's estimated that more than 84 million people in the EU are struggling with mental health problems. So 1 in 4 of us can expect to experience a mental health problem during our lifetime. And this is data from 2016. So as you can imagine, it's already outdated. We need more kind of clearer, disaggregated data. But it just does give an inkling as to kind of the importance of mental health and the need for it to be addressed concretely across EU level, national level, local level. And over the years, mental health has received more visibility, but we are yet to, we continue to advocate for an approach that realizes that while we can have more visibility on a topic, we need to ensure that there is the right approach that aligns with human rights. And mental health is something that we consider to lie on a continuum from good mental health all the way to psychosocial disability. And it's not a state, but it's something that fluctuates and is something that as human beings we all experience. So mental health prevention and early intervention mechanisms or adequate support services, mental health problems likely will increase. So here I mentioned intersectionality earlier, but intersectionality is a way of really understanding social relations by examining intersecting forms of systemic discrimination. And this means acknowledging that social systems are complex and so are our identities. So when we look at factors such as gender, race, disability, ethnicity, age, education, among others, they really intersect and interact to shape who we are and the challenges that we face. And many of these might be present at the same time in a person's life. So this must be taken into consideration when we look at suitable and tailored intervention mechanisms. People in vulnerable situations and marginalized groups, including those without shelter, ethnic minorities, women, and those grappling with challenging socioeconomic circumstances face an unequal burden that impact their mental health. And when we talk about structural discrimination coupled with limited access to adequate mental health support, this perpetuates these inequalities, preventing people in vulnerable situations from, accessing adequate care. And the intersection between mental health and homelessness is complex and multifaceted, and significantly influences the experience of individuals and families that are confronted with these challenges. So all in all, I say this, I make it long-winded, but understanding these intersections are really crucial for for recognizing and ensuring an intersectional approach, and recognizing that failures in this can perpetuate barriers, making the goals of equal and equitable healthcare system unattainable. So as we have discussed, there are major barriers to still achieving good mental health and social resilience. And we believe that it's essential to adopt a model called the psychosocial model of mental health to really address these structural barriers and provide tailored support. And this remains imperative to make progress towards a recovery-oriented service. The shift towards the psychosocial model of mental health is enshrined in the UN Convention on the Rights of Persons with Disabilities, the UN CRPD, and this really changed the way that we understand disability, including psychosocial disability. And what the UN CRPD highlighted is the need to shift towards the psychosocial approach to mental health. But in the current society that we live in, and the dominant approach in general is the biomedical approach. And so at Mental Health Europe, we really push for this shift in paradigm from the biomedical to the psychosocial. And we highlight that this is important because, as I mentioned, mental health is a human experience, and it's impacted by an individual's socioeconomic environmental factors. And so in order to address this, we have to really look at these barriers that exist and address them through a comprehensive approach. And to kind of support this work at Mental Health Europe, we've created a toolkit on the psychosocial approach to mental health, which kind of breaks this down. So I'm happy to share it in the chat afterwards. And yeah, you can kind of read and look at it yourself. But what was really imperative and kind of important within this toolkit is to, highlight what we mean by the psychosocial model, because as an organization, we really push for it. And it's a question we received for many years. What do you mean by this approach? And so we've highlighted some common features of the psychosocial model that I will kind of highlight before finishing off my presentation. So psychosocial approach to mental health is really a holistic approach, and we recognize that it can look very different in various sectors, but they all have things in common. So the first thing I wanted to highlight is the common feature of respect for the human rights of individuals. So to promote a genuine mental health and well-being, it's essential for a human rights-based approach to be adopted that really does center individuals and their recovery. And what a human rights-based approach to mental health does is it calls for equal access to quality care and support that's both holistic and person-centered. The next point that I want to highlight is equal partnership, which is another feature that we've highlighted in this toolkit. And what it does is it reaffirms that individuals with disabilities, including persons with psychosocial disabilities, are right holders and equal participants in society. And a rights-based approach to mental health care calls for equal access to quality care and support that's holistic and consensual. And here I want to briefly highlight co-creation, because it's an approach that we really push for as an organization, especially as it highlights the unique perspectives of individuals with lived experience of mental health users and supporters. And co-creation is really essential because we highlight the need for better policies, better initiatives, legislation on mental health that's cross-cutting and intersects and also includes and wholeheartedly supports individuals experiencing inaccessible housing and homelessness, but we will not achieve initiatives and kind of outcomes that reflect the needs on the ground without actually involving these impacted communities. And here co-creation is really important. So it really highlights the need for participation, involving, outreach and highlighting this at all levels of decision making. And also in the process of reflecting. So if we have an initiative that comes out, that shouldn't be the end. We should really highlight and reflect on this and identify the gaps and also the successes so that we build better frameworks in the future. And this should never be done without involving stakeholders that are impacted through co-creation. Personal goals and outcomes in the journey towards recovery are self-determined is another point. So self-determination impacts mental health and allows people to have and feel control over their choices and lives. And here autonomy is essential. The fourth point is around involving communities. So this approach allows for individuals to draw on existing support structures, for example, family relationships and ties, rather than solely relying on external support. So again, this kind of connects to that sense of control and autonomy over difficult situations. And the fifth point is around kind of recognizing lived experiences and valuing peer support. So this is looking at, mental health support through a multifaceted approach. So peer support is really important, has shown to be really impactful in terms of persons with lived experience, supporting other individuals through peer-to-peer support, and this being a possible way in transforming the mental health system. And then the last point is really around holistic practices. So holistic psychosocial services are really essential to fully address the social, personal, and psychological needs of individuals, as well as promote prevention. So we need a holistic care that's multidisciplinary, that is involving different teams, rather than solely focusing on medical solutions. So I'm going to stop there, but I just want to highlight that we have a long way to go, and we need to ensure that the psychosocial approach is applied to ensure that mental health problems are addressed through a holistic approach, and that we need to address homelessness and challenges around insecure housing in all initiatives in regards to mental health, because they intersect, and most importantly, ensuring that there is no exclusion from society and that we underscore inclusion at all levels. So I'll stop there, but I'm happy to answer any questions afterwards. Thank you.
Thank you so much, Fatima, for your presentation. Now we will be hearing from Istvan Sisklay. I apologize if I'm not pronouncing it correctly, your last name, from University of Hungary. He will present his research on the situation of people living in homelessness and with psychiatric illness and mental health disorders in Budapest and their support systems. Istvan, I give the floor to you now. You can start.
Thank you very much. Warmly welcome everyone, join us. Well, hope you can see my slides in a correct way.
We can see them. Maybe you can put it in presentation mode.
I have been done it. Hopefully,
okay.
it followed by the internet.
Maybe it will take.
I will try it again. Hope stop sharing and again. Maybe in that way.
Now we can see it.
Perfect. Okay. Thank you very much indeed. So my name is István. I'm speaking from Budapest. We have a research here with my colleagues, and my co-researcher was Kata Miklós. Besides the university, we worked for a Hungarian charity service of the Order of the Malta, who is providing services for the homelessness in the capital of Hungary, in Budapest, for hundreds, more than 1,000 homeless citizens here. And we had a research with our partners from the University of Semmelweis University. Is a faculty of medicine, basically those institute department with the psychiatry and psychotherapy. They providing us questionnaires, and then we have partners the doc room within the charity service. We have a specialized healthcare dedicated to the homeless people, homeless citizens, and then we have another partners, also the one who providing care from different backgrounds, and basically working for the mental health issue, psychosocial disabilities, and or homeless resided or living in Budapest. What was our aim? Basically, first, try to screening the health status, focusing on the mental problems, mental issues, and on the internal medicine. The other focus was the research, the accessibility to the health and the social care services. Both was quite so important for us, because I don't know, guys, what's the situation in your countries, but here we have a very separated system for the healthcare and the social ones and the social care. So we are curious about both, and of course the relation between the others, and then try to identify the different barriers faced by the homeless people, especially the ones living with mental disorders, mental problems. And also our aim was to try to focus on the development, giving recommendations and try to understand the situation and then suggest some recommendations at different levels, at the national policy ones and the meso and micro level as well. Well, our methodology was, we used a mixed methodology, which means that we have a self-completing questionnaire. Our sample was more than 500 homeless people. Those one using any kind of social services, residential or community-based and so on, services dedicated to the homeless people in Budapest. You can see it was in the autumn or late month of the 2022. And then we compare this data with other surveys and administrative data available in Hungary. And also, based on these first results, we had different focus groups for the professionals from the healthcare and the social care, and also we involved, such as in the entire research, we involved colleagues who experience homelessness. And therefore we have that kind of picture. We think that was quite an interesting. We found many different and new and relatively new results, facts. Here you can read our main findings, which is somehow one of them or some of them was surprised us, at least like the homelessness people. I mean, people experiencing homeless, the average is getting older. You can see those who, of course, involved or having a connection to one or the other of our social services, 3 out of 4 is aged more than 50 years old. Of course, well, that was common, that with a very low education. And also what we faced is that more than 1/3 of the responders have 10 years or more of the homeless career. Even it is meaning the ones who are not in the residential care, so not in the housing type services of the whole social care. People living on the streets, also mentioning that more than 10 years of being experiencing homelessness they have it. Also what we see, 2/3 or more than 2/3 express kind of barriers in the community participation, employment or housing because of the health problem, anterior medicines and the mental, and or the disability. Also, what we see, it is as a self-consideration, almost 40% of the people consider themselves as disabled. So it was a huge number of them. Here you can find on the chart the self-reported overall health status. The different rows shows a different kind of surveys conducted in Hungary and in Budapest, male and female. You could see it. Yeah, I just have to skip it because you know, the time pressure. Here you will find the mental problems by diagnosis. So these contains the ones, the homeless people who have diagnosis. Of course, one of the aim of our research was try to find the hidden agenda. How many people could have or affected by any kind of mental problems, not having diagnosis, but these ones, the data for the diagnosis. What we can see, what we can find is that they are younger ones. Probably not surprised, but something we have to address it much more seriously when we're providing services, because frankly, we have weaknesses, or there is weaknesses, lack of specialized services for female, at least in Hungary, at least in Budapest. So the female have more barrier. 80% of the ones with diagnosis need regular medication. However, out of them, 40% reported different kind of problem of the medication. Yes, the money counts, basic, but not only, because there is the financial medication, the financial reason for not having the proper therapy, but the access also they mentioning, the regularity, all of the kind which is created a barrier. So one of the aim is how we could, or we at least try to overcome with this. For instance, we are just thinking about a kind of telemedicine, teleconsultation, using the smart phones and so. Maybe it is not surprise, but somehow we experience it in the Hungarian case, at least the social carers, the social workers are not ready to use that kind of channels, that kind of tools. However, of course, from the everyday life, from their personal life, they use it, we are using it, but as a professional tool, it's somehow, we have to improve it, I guess. And there is definitely a need and an opportunity. So one of the issue for the future is to focusing on it. How could we deal with this issue? It was also stated that 1 in 4 have no consultation with any health doctor during the last year. It's something we should not accept. Also, we have to. It shows us the barrier or the access problems to the healthcare. However, more than half of them had a consultation with a psychiatrist. Basically, the psychiatrist provided by the social care, within the social care, so not in the healthcare system. We found 2 relatively new phenomena. One is the dementia, even under 40. Basically, they're living in the residential care with other homeless people, but it's something difficult. It's yeah. I don't think so that I should explain more, but that it's something also a new one. Find dementia, and the other issue is the attention deficit hyperactivity disorder we detected, screening it with these questionnaires. Here you can find, I will not going into the details, the different kind of mental illnesses in the responders. Here you will find, of course, you could see the depression, the distress, and so on. I will not through it. And even the schizophrenia or the other major issue is detected. And then you will find, you could read here the associated diseases, the depression and the distress, or depression with the mood disorder, or you will see the distress plus the mood disorder. So something which underlies the necessity of improving our services, which is needed. Here you will find our recommendations. At the national level, I might say that we have to have more attention to disseminate the Lisbon Declaration on the European platform on, the combating homelessness, something which was very purely known by the social workers during the focus groups and then interviews. We found that too many, I might say that too many people do not know, do not hear about the Lisbon Declaration and why it is important. Also, we found it, there is more knowledges within the social workers, caretakers working for the homeless people, more knowledge about the UNCRPD, its rights-based approaches, but how to apply it, what does it mean in practice, even talking about the psychosocial disabilities and that kind of new phenomena, as just Fatima mentioned. That is something we have to deal with it in different approaches, because there is or should be consequence on the everyday practice as well. And then also the third document we have to share it widely at the Hungarian national level at least is the deinstitutionalization. And that's meaning not only, not exclusively on the different other kind of the disabled person and disability, but also applied in the homeless issues as well. That is something, another task for us. Having recommendations at the service level, we definitely underline the need for strengthening the community-based care capacity. Also, we need urgent need for the social housing programs, especially with the for the homeless people with mental illness. We implementing in Budapest housing first. That's fine, but in many cases, without lacking or not having access to the healthcare, to the social, community-based social care, simply it is not enough, it is not manageable. We faced with it. Even the service providers have a kind of fear of how to maintain, how to provide such a service for people with mental problems. So definitely we should focus, we should specification, having specification, I think, I am not sure, but need for this kind of housing problems. Also, at the service level, should focus on the education, re-education. Yes, it's obvious. Taking care this more than 20 or 10 years. There was some who have more than 20, but 10 years of the homeless career. Definitely much stronger cooperation between the health and the social care. It is needed. Yes, it is needed at the national level. So by the legislation, by the finance, basically we started it. I mean, modification of the legislation and the financing schemes in order to let the cooperation manageable between the health and the social care, because they are a totally different system in Hungary. And we face that in quite so often, I might say that there is a real lack of the cooperation, even changing the information and so on and so on. Also, what we found is not only the lack of the cooperation between the health and the social issue, but within the social services. I mean, the specialized services for people with mental problems, and it is the different ones from the one focusing on the homeless people, homeless citizens. Even within two social workers, one working for the mental problems and the other with the homelessness, no connection, no real relation. So therefore, we need such a case management stories, etc., etc. Actually, we have the tools, should apply. So that's why we have to focusing on it. Yeah. And basically, I will stop here. So I might say that in the as a result of this research, we have just started to improve our services, sharing the information with the others, with the governments, with the decision makers. And now I might say that we have at least a little progress, but we are at the beginning of the road. And I'm sure that it would be nice to have, a partnership or to share experience, because we feel that it is a much more complex issue, and that's a hard one, definitely, or one of the hardest ones. Even as I'm mentioning, the social workers dealing with the homeless people have to be educated, have to support in that way. What is the differences? What is I might say that extras have to consider in case of the people with homeless and mental disorders, mental problems, because very often the social workers feel they are alone with that kind of programs. They have fears, lack of knowledges. Even sometimes they thought that that's too much for me. That's not for me. I'm not, educated for that issue. So therefore, we have to deal with this issue. Okay, thanks. So thanks, really. I would be interested in what is your experience in that cases. Thanks, really.
Thank you, Esteban, also for sharing the challenges that you face in Budapest. Since you have to leave in a few minutes, I will ask if someone has a question now. I see that there is a question from Mark Peder in a chat that says, do you think there is some shame attached for patients admitting their own mental health diagnosis, particularly because of the stigma within mental health? That maybe you or Fatima can answer.
Fatima, would you like to
It's
answer?
fine. You go ahead. I know you're short on time. I can add on.
Well, okay, thanks, really. Short answer is yes, I think. However, what we face that when we have the interviews, when the homeless people fill out the questionnaire, we couldn't detect statistically, couldn't approve that kind of hiding or shame or stigma, of course. It was not in connected to the mental problems, especially the ones who have, the I might say that the license of having a problems. We found much stronger problems with the addiction, especially the drug using and the mental problems and the homelessness. So the hiding factor in that cases was much higher. We saw it, but it's out of question for us. But there is definitely this stigma, and there is a consequence on it. So I'm sure that we are sure that it is an issue. Yeah.
I agree with everything with what you've mentioned, Esteban. Indeed, when it comes to mental health in general, we're not yet in a place where there is, open communication around mental health and dialogue. And I think that's also reflective of, our education system, and also in general our communities and the way we talk about mental health. So I think there is most definitely a stigma attached to mental health, but also a lack of resources and also accessible information to reach out to communities and individuals in a way that's culturally sensitive and is able to really highlight that it's something that we will experience, and also where they can go for support as well. Because for us, I think one of the challenges is seeing mental health as simply something that you have to diagnose, rather, and instead we see it as something where there needs to be an open communication about where we are with our mental health, as I mentioned, on the continuum, and therefore referral pathways and support that fits an individual needs, whether that is, for example, going to a mental health professional to receive support, or receiving support from community-based services, etc. So it really, I just underline the need for kind of that holistic approach that's really missing from the healthcare system and in general various sectors. Esteban.
Yeah, may I just to reflecting what Fatima you said. Yes, when we are talking about the colleagues, professional ones dealing with the mental issues, they underline the necessity for the so-called the natural supporters, the neighborhooding, the relative, so those ones who could support the people with mental problems out of the professionals. And of course, what we found here in the case of the homeless citizens, there is no chance, or there is no this kind of so-called the natural supporters or the informal helpers, supporters. So it could be a challenge for the services, our services. How could we replace it or try to build something which could functioning as in other ways? In case of the not homeless people, this kind of neighborhooding, not professional helpers to help the recovery of the mental problems. So that's a huge challenge.
Definitely, it's definitely a gap that exists there, but we need more investment, focus on mental health. Just a quick example is in Greece, there is something called the mental health mobile units, where it's mental health professionals, also those who can provide kind of tailored support within communities, are moving to provide the outreach. And that, for example, is a really positive practice that we've highlighted in our toolkit that's needed in other areas, based on what will work, of course, within the society. But it's a gap that exists, and I think because these gaps are so prevalent and we haven't addressed it yet, this can contribute also to the stigma and the shame around mental health. So yeah, thanks.
Thank you. Esteban, there is a couple more two questions that are similar in the chat. I don't know if you can take. It's regarding the Budapest. If you still have time.
A few minutes maybe, because sorry, really sorry, but I have to.
I know. That's why I'm asking. But maybe you can briefly tackle. We'll read it. Thank you, Annika Hausberger. She says, thank you for your presentation. How does the actual political and harassment against homeless counteract any social and health programs in Budapest?
Okay. It's a good question and a difficult question. We are not in an easy situation, of course, regarding this phenomena coming from the Hungarian social policy or from the Hungarian government. However, yes, there was an effort to try to actually to push out from the community used spaces, public spaces, the homeless out. We felt it, however, now what we can see there is a, how should I say it? It is, but people still living on the street in Budapest. You could see it, unfortunately, or fortunately or unfortunately, it's up to your viewpoint. Fortunately, because at least we could see them and we could reach out them and we could offer them help. Unfortunately, because it is not an easy to solve such a situation. So therefore, still there is a need for more social work, or basically what it is the most urgent thing is in this matter is the housing. We should need more housing, or even talking about in a nationwide housing policy, a much stronger housing policy is needed. So that would be the solution. But nowadays, what we can see is the situation is something like that, as I mentioned. Yeah. Thanks.
Thank you, Esteban, and thank you for joining us. We
Thank
will
you for the
continue.
invitation. All the best to you. Thanks. Bye. Sorry
Thanks.
for the.
Bye.
Thank you.
I see that we still have some questions, but now we will continue with our two presentations that we still have left, and then we will come back to the questions on a Q&A session. So now our third speaker is Paula Reed. She is the Research and Policy Officer at Neuner House in Vienna. I also would like to highlight that their service was selected as a good practice by the European Commission. So now I give the floor to you, Paula. Thank you.
Thanks very much, Raquel. Thanks for the invitation to present our practice here today. And also, I'm very grateful to the two previous speakers for having done such a great job in providing the context and background for me, which means I should hopefully be able to stick to my time so that we get to discussion. So today I want to talk about a mental health practice that we at Neuner House, which is a social organization based in Vienna, providing services in the areas of housing, health, and social participation. And since 2021, we've had a mental health practice. The practice is based in our health centre. So I just want to give a quick bit of background on that to provide some context for our mental health service. So the Neuner House Health Centre is open to people experiencing homelessness and people who do not have health insurance. And last year, nearly 6,000 people were supported through the health centre. It comprises of a couple of different services. There's a general practice, so we have GPs and a nursing team who have a specialisation in the management of chronic wounds and wound care. There's a dental practice. We have a team of GPs who do outreach work in homelessness services across Vienna and also offer a health telephone helpline. And as mentioned, since 2021, we have the mental health practice. Also, because it is really integral to the delivery of health services at Neuner House, we have a team of social workers and peer workers also based in the health centre, because we believe you just cannot separate health needs and social needs often for people experiencing homelessness. All the services in the health centre are free. As I mentioned, they're open to people without health insurance. People don't have to provide any proof of entitlement. They can be used anonymously. And we also have video interpretation available in over 50 languages, so people can be supported in their first language or language of preference. So for all the reasons that have been outlined by the previous two presentations, we knew that there was a significant need for mental health and psychosocial support in our patients in the health centre. And we also knew there were a number of barriers to access services for that group. So we wanted to develop a practice that would improve access. And actually, even though the practice started in 2021, our work on it started much earlier. So in 2018, we were able to run a pilot project, and that involved consultation with a number of stakeholders across the homelessness sector here in Vienna, mental health experts, and also crucially people experiencing homelessness who required mental health support, had maybe tried to access mental health support in the past. So also getting that expertise into those discussions. And we developed a concept for a low threshold mental health service and piloted that in 2018, 2019 in the Neuner House Health Centre. So then we had a concept, but it took us a little while to be able to find a funding opportunity for that concept. So I suppose one thing from my presentation today is also, if people do have these concepts, do stick with them and keep an eye out in case there are funding opportunities for them to be implemented. And in 2021, we were able to get funding from the social ministry here in Austria to set up the mental health practice based on this concept that we had piloted a few years earlier. And we're also lucky enough to then get a second pot of funding in 2022. And so the funding for the practice is currently running until the end of this year. So what we wanted to do with the mental health practice was provide high quality, interdisciplinary, low threshold access to mental health support for people experiencing homelessness and those without health insurance. And when we talk about low threshold, there was a real focus on removing some of the common barriers to access we knew people had when they tried to access mental health support. So there was no requirements for health insurance. The service was free. It could be used anonymously. People didn't need a referral, a specific diagnosis. People didn't need to make appointments. Again, we know that language, being able to talk about, particularly, I think, in the area of mental health, being able to talk about the support you need in the language you feel most comfortable in is very important. We also wanted to think about how we could we talked a little bit about stigma in the conversation beforehand, and how difficult it can be maybe for people to take that step to accessing a mental health service. So how could we maybe take away some of that, provide flexible settings, make it as easy as possible for people to come into contact with the service. We wanted to make a contribution to improving mental health literacy for people. And also we saw the service having the potential to connect people to other services, whether that's existing mental health services in Vienna, and it was just that people needed a bit of extra support to access them. Maybe it was other type of health support within our health centre, or maybe another type of social support. So we saw the potential for this service to also provide a bit of a bridge function to other forms of support people might need. So the mental health practice has 4 kind of service components, or 4 bits to it. And I want to start with the part of the service that is used the most by people that are in contact with us. And that's what we call Zeit zum Reden, or time to talk, is the English translation. And that maybe sounds very simple, but it's something that we've seen has a huge impact on people who access the service. So the team for the mental health practice is interdisciplinary. There's social work, general medicine, there's qualified peer work, a psychiatrist and nurse. So it's a very interdisciplinary team. And the idea behind time to talk, Zeit zum Reden, is that the team is just available and present and visible during the opening hours of the Neuenhaus Health Centre. So they're in the waiting room, they're out front if people are getting some fresh air before coming in for their appointment. We have a cafe, the Neuenhaus Cafe, directly next to the health centre, which is also an important contact point for people, and the team is also visible there. And so there's no wrong way into the service. The team can approach people proactively if they think people might be experiencing distress. The team can be proactively approached by people just sitting in the waiting room or on the way in and out of an appointment, with other services within the health centre, or other teams within the health centre can connect people to the mental health team. So there's no wrong way, and there are multiple routes into the service. People don't need to make an appointment. And people also don't have to have a concrete topic that they want to talk about, or a concrete problem. I think that's one of the interesting things about the practice is, I think in a lot of health and social care services, because there's so much time pressure and resource pressure, often people have to come with a kind of a very clearly defined problem, and then a professional works on a very concrete solution with them. And what we wanted to do with this service was create a bit of space and time and openness to take some of that pressure off, and just to give people an opportunity to talk about whatever it is that was important to them. And there might not always need to be an action that comes from that. We constantly hear feedback that just having someone to talk to, I think Istvan mentioned that in his research, that people don't have the social networks. They don't necessarily have people in their private circle, or in terms of the professionals they're in contact with, that they can just talk to. And it doesn't have to be defined in a sort of advice setting or a problem setting. And also the interdisciplinary team, when they're in those conversations, aren't necessarily there in their professional role. So somebody isn't necessarily in this part of the service in time to talk, having a conversation with a social worker or having a conversation with a psychiatrist. That takes a slight back seat, or is not sort of not in the foreground of this part of the service. It is someone at its most simple that has time to talk and time, importantly, to listen. And we found that taking a more open approach to the kind of the goals or the results of these conversations has been has seen really interesting results. And the amount of times the team gets feedback that people are surprised how useful just talking can be, and just having 10 minutes to get off their chest whatever it is that's been stressing them or weighing on them can actually have a significant impact, and can also be a way in terms of building up relationships or building trust in the service that then allows them to take a step to another part of the service. So this time to talk element is really the core of the service. As I said, I think it's by far the part of the service that is used the most. And it sounds simple, but there's actually quite a lot to it in terms of how the team work, how the offer is structured, and how people come in contact with it. So next to time to talk, there's 3 other parts of the service. The first is a psychiatrist clinic that's open twice a week. That's the only part of the service that does require a referral and an appointment. But that referral doesn't have to be from within our organisation. It's also possible for other organisations within the homelessness sector here in Vienna to refer people to the psychiatrist. We have weekly group discussion sessions. One is open to everybody, and then one group we've set up just as a space for women to talk to each other. Again, Istvan talked about the additional barriers women face in accessing services, and so we wanted to have at least a small space that was just for women within the service. And the 4th element is a program to support people to reduce their alcohol consumption. In Vienna, there's a particular gap in provision around support for alcohol for people who don't have health insurance. And with this program, we wanted to try and address that gap. So it follows a concept called kontrolliertes Trinken, controlled drinking, which is a structured program. The majority of the team is qualified in the program, has completed the training. And there is a focus, as Fatima was talking about, on autonomy and self-determination. So the goal of the program isn't abstinence. People don't have to have abstinence or completely stopping drinking as the goal. Instead, the aim is to help people understand their alcohol consumption and to reflect on the changes that they want to make and support people to implement those changes. It's about increasing health literacy and increasing people's confidence in making those conversations and in implementing those changes. And that support is offered in one-to-one settings. And again, with different members of the team, different professions within the team have all undergone that training. So the service opened in September 2021, and the numbers to the end of September this year were that there have been over 4,400 contacts with the team. We talk about contacts because, as I mentioned, people can use the service anonymously, and because somebody could come and talk to somebody one day and then 4 weeks later comes and talks to somebody else, we can never exclude the fact that we might count people twice. So we talk about contacts rather than people. 3/4 of those contacts are through this Zeit zum Reden offer. And we really see that making a significant contribution to tackling isolation and loneliness that many of the people that we speak to through the practice feel. And the key themes that are brought up with the team are health, unsurprisingly, given that it is embedded within a health centre maybe, housing, also not particularly surprising. And then also the third significant issue that people talk to the team about is kind of family and other relationships. We see the impact within the health centre of having that interdisciplinary team. It relieves pressure on some of the other teams that in the past would have had patients come to them with issues that weren't necessarily within their professional area of expertise, but they could see that there was a real need for support there, and being able to signpost to the mental health practice within the health centre, again, remove some of those barriers. People don't have to then go to another place to access support. but as soon as they walk out of one appointment, they can be supported by somebody if that's what they want. There's an ongoing process of reflecting on how we've implemented the practice and refining the concept and how it's delivered to ensure it's meeting the needs of the people that are using it and accessing it based on the feedback we get. From the beginning, we've really tried to share learnings from the project nationally and internationally through webinars like this and also at conferences. And Raquel mentioned we were delighted earlier this year to be recognised as a best practice by the EU Commission. And we've also been officially recognised within Austria as a measure to improve mental health literacy. And which I think is also a key part of this. It's about giving people the tools, the knowledge that they maybe already had, but didn't even recognise the kind of resources that they already had and help them strengthen and develop those to be able to understand their own mental health and maybe the things that they can do to feel better or where they can turn to if they know that they need support. Sorry, that was a bit of a download of information, but I hope it's given you some insight into the work that we're doing, and I look forward to the discussion later on.
Thank you, Paula, for such an interesting presentation. Our finalist speaker is José Carrillo. He's a housing support technician from Hogares para la Autonomía from Madrid. He will make his presentation about the relation with Housing First and mental health. José, you can start.
Hi, good morning, everyone. Well, as Raquel said, I'm Jose. I'm a house support technician in Madrid. My team and I work in a model called Housing First, within the model called Housing First. And I'm here to discuss today a problem that affects millions of people, which is homelessness, and to discuss that and its link with mental health. In general, as a society, we think about homelessness in terms of basic needs, or not having basic needs like food, shelter, and safety. But what's often overlooked is the link between this situation and the mental health of people living in it. So it's not just about losing a physical home, it's about the trauma, the stress, and the mental health challenges that go with it. People experiencing homelessness face unique mental health challenges that are often intertwined or tangled with their lived experiences and traumas they have suffered. So when we talk about mental health, we refer to basically emotional, psychological, and social well-being, right? It affects the way we think, the way we feel, the way we act. And unfortunately, when people live in this situation, their mental health, and because of this, the way they think, the way they feel, and the way they act is very impacted. Here we can see some data regarding mental health, the things that we see working close to the field. As it says there, homelessness is not compatible with the right to health. We can see that very well if we look at the risk of having mental health that you can find in the general population. Basically, 18% of people are at risk of suffering any mental health issue, while when we talk about homeless people, this number rises to 6.9, which is almost 50% increase. When we talk about having some depression symptoms, we can see the same trend here. Homeless people, 59.6% of people who live in a situation of homelessness are more likely to develop depression symptoms than the general population, which is only at 12.9%. When it comes to trauma, or as we define trauma, which is any non-desired, sudden, stressful event that has life-changing consequences for the people who suffer it. In the general population, we're likely to suffer up to 3 traumatic events throughout a lifetime, while homeless people can suffer up to 8. When it comes to women experiencing homelessness, we have significantly different data. Roughly 23% of the people experiencing homelessness here are women, and their numbers differ a lot to the numbers of men experiencing mental health. As we can see here, 82.5% of women experience some sort of poor mental health. Roughly 20.6% of them are diagnosed with depression, borderline personality disorder, schizophrenia, or bipolar disorder. These are the most common disorders that we see in women in this situation. 35% of women present depression symptoms, and 26% present PTSD symptoms, or that's post-traumatic stress disorder. Of these women, 56% has suffered violence that's specific of their gender. And this number rises to 67% if we include in this definition of violence, controlling behaviors, threats, and verbal abuse. We've talked about trauma, and we know that it's at least present 3 times in the lives of people who are experiencing homelessness. We can see trauma as a precursor to this situation of homelessness. Research shows that many individuals who end up experiencing homelessness have faced significant trauma at some point in their lives. This trauma, it often starts in childhood, and studies have shown that in women, again, nearly 40% of them have experienced physical abuse during their childhood, and almost 30% of this violence has been related to a sexual assault in any degree. There's also the very stressful event of actually losing your home. It's incredibly stressful. It's obviously life-changing. And for many people who have to face this situation, it's tied to other stresses such as family violence, relationship breakdowns, or financial instability. A study conducted by Miguel Ángel Navarro showed that a significant number of homeless individuals had gone through traumatic divorce or separation right before losing their homes. And there's also the ongoing stress of having to survive, of having to live on the street. Once they are on the street, we know that these individuals experience the daily stress of having to fulfill their survival needs. They're exposed to any sort of violence, that being physical or verbal, and they're exposed to social exclusion and the fear of stigma. A report done by the Hogarsi Foundation found that around 47% homeless people who participated in the study had suffered any sort of violence in the last 6 months prior to conducting the study. We can also talk about the vicious cycle that exists between homelessness and mental health, because when we talk about mental health, we can talk about it as a cause of homelessness and as something that worsens it, that makes it worse. The emotional trauma of the emotional toll caused by trauma, anxiety, and depression makes it harder for individuals to maintain a house, employment, relationships, or even simply accessing the services that they need. These factors obviously make it more difficult to escape this situation of homelessness, or make it easier, if we look at it from a different perspective, to become homeless. Without stable housing, logically, people in this situation struggle more than anybody else in accessing the treatment they need for the specific mental health needs. In addition to these challenges, many people who experience homelessness face additional barriers to accessing mental health services. This includes maybe lack of transportation, the fear of being stigmatized for the conditions, and sometimes even if they access these services, they don't have, or they can't obtain the support, a support tailored to their very specific needs. So what's the role of Housing First in all this? We see it as one of the most promising approaches to addressing homelessness and the associated mental health and drug addiction challenges that usually come with it. This model sees housing as a human right, first and foremost. So mainly it provides individuals with stable housing as the first step in their recovery. It's the first thing that we do. It's provide a house for the people using our services. By doing this, we make it easier in the near future to establish a bond, a relationship with the people who we work with, and make having a house from the first step makes it easier to address these other issues like mental health. The idea of this is simple but powerful. You can't effectively address someone's mental health if they don't have a stable and safe space for them to be in. Our evidence suggests that it's a model that works when it comes to tackling these issues. A significant study on the Habitat Housing First program shows how providing stable housing leads to improvement in both housing retention and mental health. After 18 months in the program, we could see that 98% people who use our services remain housed after 18 months, that's a year and a half. And not only did they stay housed, but they also showed improvements in mental health, social relationships, and their sense of security. During this period, our participants also experienced fewer instances of victimization. Victimization being literally being the victim of any form of aggression, and they also experienced reduced discrimination. Their mental health scores also improved, showing a notable decrease in depression and anxiety levels. So I like to leave with this sort of reflection. Okay, in conclusion, homelessness is not just about lacking a roof over your head. It's a deeply traumatic experience that touches every aspect of the person who's experiencing it, and it can come from anywhere, from childhood abuse, to family violence, and just the trauma of living on the street. People experiencing homelessness face a lot of very specific challenges that need to be addressed. To be addressed effectively, we need solutions that tackle both homelessness and their access to housing at the first time. And the Housing First model has proved that when people are given a stable place to live, they can begin to heal mentally, emotionally, and socially. So thank you very much, and I'll be happy to answer any questions that you might have.
Great. Thank you so much, both of you, Jose and Paula, for your presentations. There's a lot of insightful information, and there were questions in the chat at some point about the impact, and I think that was partially answered by Paula. You've mentioned some data on your services and how you reached people. If you want to add anything on to that, or maybe Jose, if you have anything on the results that you've achieved within your project, we can take a few minutes to do that now. If you have any other questions, everyone, please put them forward. And also, for the two of you, there was a point mentioned earlier by Istvan, which I think it comes up all the time, about training for staff, and how is this being, like, we need to invest more in it, that's for sure. If you have any examples as well about that, please. Paula, if you want to get started.
I can get started. I'm just trying to find the comment about impact.
I can read it, maybe. It says, do you have any data to share about the impact of community-based housing on mental health outcomes? When these recommendations are implemented, what is the impact?
So obviously our practice is a sort of a health practice rather than a health practice within a homelessness service rather than a housing based practice. But I think in terms of impact, it's often really what we hear back from people, and I mentioned it in the presentation, about the sort of not having anyone to talk to and not always knowing where to turn to. I think stigma plays a role as well. I think there's a huge, that we hear that as well from the doctors, and for example in our GP practice, that when they're in a consultation with somebody and somebody mentions a topic where they feel like the mental health practice might actually be then a good next step for that person. The minute sort of mental health gets mentioned or it goes in that direction, people instantly are skeptical. I think we also have to take into account that lots of people, if they have had previous contact with mental health services or health services, have often had very poor experiences in many settings of having those contact with mental health services. So I think that's why the kind of the time to talk, the low threshold access has been so impactful, because I think it can really change people's understanding of what mental health support can be, of what mental health is, of how they can maybe take steps to keep an eye on or look after their own mental health, maybe recognize what things that are difficult for them and where they might be able to turn for support. So I think there's sort of a lot that goes into this time to, there's a lot of impact within the time to talk service that is difficult to, that is then difficult to prove with quantitative data, and comes a lot more through qualitatively, and how people's maybe perceptions of seeking and receiving support have been changed through this kind of just low threshold. We're just taking some time to have a conversation. There doesn't necessarily have to be and now there'll be a referral and you're then in this system and it will go like this from here. So I think that's sometimes a bit of the difficulty with this service is, I think we all intuitively know that having that space and time to talk, we all do it with friends, family, colleagues. You know, we all take that opportunity to just go, oh, I need 5 minutes to talk about this, and this, and this. And often there just isn't the time and space within social services to do that, because everyone is under so much pressure. Resources are tricky. So I think a lot of what we've seen in terms of impact is qualitative, or we have qualitative data for it rather than quantitative data for it. But we are definitely seeing there is an impact. Oh, and training, sorry, training you asked about as well. So we have an interdisciplinary team that obviously have lots of different professional backgrounds. And this kind of profession-free way of working, where they're not necessarily first and foremost in their role as a social worker or a psychiatrist in a conversation with somebody, I think has prompted quite a lot of reflection in the team around professions and training and skills, and also the the ability within the team to have that interdisciplinary support and exchange with colleagues. But in terms of what concrete training is needed, I think it will depend so much on the context of the service, the context of the system that they're working within. So I'm struggling to give a concrete recommendation on that, I'm afraid.
Maybe we can hear from you, Jose, a bit on how you do it in the Housing First project and about training. I know there's a lot of training within Housing First, but perhaps also in connection to mental health.
Well, as I think I said before, we are a housing service. So my team in specific, we mainly provide our participants with a house first and foremost. So when it comes to impact, we're seeing it every day. Basically, other than the house, we provide an all-around support to the person, but always tailored to their needs. So it takes time for us. The first few sessions with them consist mainly in us trying to develop a good relationship with them by providing this person to talk to trust. We mainly make the person the protagonist of their own process, and we are able to use this trust they have in us to tailor the intervention around that. So for that, we use the house as a base. This makes everything easier. Having an address is tied to being able to access your local community and social services, is tied to being able to access healthcare. It's basically tied to everything. So by providing a house first, we make the rest of the process easier, while practically putting a roof over someone's head, someone who before being with us was literally living on the street. So even though we see an impact over time, we can see the impact daily in our work. And when it comes to training, we are a very multidisciplinary team, obviously more towards the social side of the academia. We have social workers, psychologists such as myself, social educators, but we do have this sort of side displays in which we train daily. We're constantly offered courses on how to change the way we see ourselves as professionals, changing the way we look at this problem and the way we look at the job that we do with these people. And we're always trying to learn and to adapt to their needs as best as we can, because as I said before, that's the whole base of our model.
Thank you.
I hope that answers
thank you for highlighting
the question.
I would like to quickly go to Fatima as well, if you want to share anything on training from the perspective of the work that you are doing and your members as well.
Yes, thank you so much. Indeed, I echo what other colleagues have mentioned in terms of training. We think it's really important, especially when it comes to mental health literacy and ensuring the right approach. And we look at mental health through the curricula. So, starting dialogue from primary school, but all the way to professionals that are either entering the mental health field or will be working in sectors that cross-cut with the topic. And for us, we are working on a project called EU Promens, which is looking indeed at training for professionals and ensuring that there are connections between various skill sets. And we highlight that, especially when it comes to mental health, the psychosocial approach to mental health should also be integrated into the education system as well. So when we talk about mental health being a human experience, ensuring that we look at mental health support as being diverse, and that we need to work towards a society where this is reflected, so that tailored approach. But we have a long way to go, but there are fantastic groups of different associations, such as associations for students in psychology, etc., who are advocating for this on the ground. And then we collaborate with them to push for the advocacy goals. So yeah, I'll stop there. Thanks.
Thank you. I am aware that we are we are at the end of our time as we scheduled it for today, but if you have a few more minutes, I think just the last question would be in connection to funding, and there's a couple of questions as well on the cost and cost reduction to other services, cost benefits, and I think, again, just to say that this is also something difficult to measure, but if any of you has anything to say about funding, where it comes from, and how you collaborate with authorities for funding or beyond funding on advocacy, anything that you can say on that, it would be helpful, I think, for our guests today. I think, Paula, you already mentioned you're getting funding from the ministry. Maybe if you can say a word on how that was possible.
Yes, so we've had two projects funded by the ministry. The first was actually the first year of the project, 2021-22, was funded through kind of a special pot of funding that was made available through the ministry to reduce the risk of poverty and the social I cannot think of the word in English, only in German. The social consequences of the pandemic. So there's a very specific funding pot available. And again, sort of going back to what I said in my presentation, sometimes we'd had this concept for a number of years and hadn't been able to get funding for it. And then it was a particularly good fit for this funding pot. And then the second project funding came off the basis of discussions following the first project. But that funding is going to end at the end of this year. And I think a cost benefit analysis, somebody asked specifically if we had one, unfortunately not. And I think it is something we would love to have. For a lot of the work we all do is around prevention in some shape or form. And I think that's something where it is often very difficult. And I would love if other people have examples of where they've managed to make a cost benefit analysis, maybe in partnership with health economists or anybody. I would be really interested in hearing examples from people about how they've managed to make that happen, because it's data we would love to have, and just don't currently have the ability to do that.
Thank you. Jose or Fatima, would you like to add anything now that we are going towards the end of the webinar?
In our case in Madrid, when it comes to funding, the foundation receives both public and private funding. But in my team's specific case, we receive funding exclusively from Madrid City Council. There's a public funding for homelessness in the City Council of Madrid. So we are in charge of administering, managing that in our area. So basically my team is funded by public money.
Great.
Just to add on, so our funding primarily comes from the EU. So we receive an annual kind of operating grant, like many organizations, umbrella organizations, but we also do receive some funding from initiatives such as Selena Gomez's, for example, Rare Impact Fund, where we work with youth leaders across Europe to advocate for mental health, and small pots of funding like that. But the primary funding we receive is from the European Commission.
Thank you so much. Thank you all of you for your presentations and the resources you've linked in. Just to say to everyone that we will be uploading the recording as well as links to the presentations from today on our website. And we are very grateful for your interest, for all this information that indeed, as someone said in the chat, chat, Julianne. Thank you. It will be very useful for our future work. We are already 6 minutes over our time, so I will not try to summarize all the rich information that you've presented today, but I will just say that indeed, this was the last webinar on health issues at FEANTSA for this year. And next year, we have other exciting activities in connection to health inequalities. We will continue to follow European developments, such as the comprehensive approach to mental health. But we work a lot on the European Platform on Combating Homelessness, where we try to bring health into it as well. So we will be in touch. Write to us if you have questions or for any other resources. We are available, and you can find our emails on the website. So yeah, once again, thank you to our speakers, and have a great rest of the day.
Thank you. Likewise.
Thank you,
you.
everyone.